Good morning. My name is Marla, and I will be your moderator for this workshop, Graft-versus-Host Disease, Skin, Hair, and Nails. I'd like to thank Insight Corporation and Sanofi, whose support helped make this workshop possible. It's my pleasure to introduce today's speaker, Dr. Alina Markova. Dr. Markova is a board-certified dermatologist at Memorial Sloan Kettering Cancer Center, who specializes in treating skin conditions that result from bone marrow transplantation. Her outpatient clinical practice is devoted to caring for people affected by graft-versus-host disease. As co-director of the multidisciplinary GVHD clinic, she partners with oncologists, hematologists, nurses, and other experts to provide patients with comprehensive care to effectively address their symptoms. Please join me in welcoming Dr. Markova.
Thank you so much, Marla, for the kind introduction, and it's a pleasure to speak with all of you today about graft-versus-host disease of skin, hair, and nails. So today we will understand the various ways chronic graft-versus-host disease can affect the skin, hair, and nails. We will review the timeline of manifestations of chronic GVHD on the skin, hair, and nails. We'll describe how cutaneous GVHD can affect daily activities of daily living. And we will summarize pharmacologic and non-pharmacological therapies that can help patients who have cutaneous GVHD. So I'm sure you've learned a little bit about GVHD already, and there are two main presentations of cutaneous GVHD, one in the acute phase and one in the chronic phase. Traditionally, acute cutaneous GVHD presents in the first 100 days, and chronic presents in the after 100 days post-transplant, but either type can present at any time, and we really diagnose this based on the presentation on the skin and not based on the timeline. So I will first start by discussing acute cutaneous GVHD. Acute graft-versus-host disease of the skin may present with pink, flat, and raised areas. This may be itchy. It can be localized just to the face, to the neck, to the hands, or it can really be generalized. And the symptoms can range. Some patients may be totally asymptomatic. Others may be very itchy, even have burning pain, and have symptoms that disrupt their sleep. Rarely, acute graft-versus-host disease may become bullous and blister, and this is considered to be stage 4 acute graft-versus-host disease. The severity of acute GVHD of the skin is determined by the percent of involved skin. So if you have no involved skin, then it's stage 0. If less than a quarter of your skin is involved, it's stage 1. If 25 to 50% of your skin is involved, it's stage 2. And over 50% is stage 3. And lastly, if you have over 50% of involvement of that redness and pinkness, plus about 5% of your skin is blistering, that's considered to be stage 4. And this staging really helps guide treatment. If it's an extensive rash, really stage 3 enough, that's when the transplant physician will oftentimes use systemic therapy. So how do we manage acute graft-versus-host disease of the skin? The topical approach to therapy is typically first line for localized graft-versus-host disease, and we have creams in our armamentarium, and we also have light treatments. So topical steroids, topical calcineurin inhibitors are really the creams that we have available, and also phototherapy. And for acute graft-versus-host disease of the skin, we typically use narrowband UVB phototherapy. And so topicals can come in different vehicles, and the vehicle is really how the topical medication is presented to you. So it can come as a solution or a spray, a gel, or a foam. And these that I just mentioned contain alcohol. The alcohol makes them more easy to apply, so they're great for hair-bearing areas. They're great for applying to an extensive body surface area. But because of the alcohol, if you have any broken skin, they can actually create a burning sensation. And so for patients with broken skin or localized areas and non-hair-bearing skin, we oftentimes recommend creams, oils, or ointments. And these do not have alcohol. They're water and oil-based and are better tolerated. They also moisturize due to their oil or petrolatum base. So if you're ever prescribed a topical and you find that it's not the right quantity, or you don't like the vehicle that it comes in, you can always ask your provider to send you an alternate. And you can ask, for something that's less greasy, for something that's easier to apply, for a larger quantity. And that's something that can be easily prescribed, as there are many topical steroids that have equal efficacy, and they come in different preparations. And so always important to ask. So our topical approach for management of acute graft-versus-host disease, as I mentioned, most of the treatments are applied twice daily. So topical steroids can be applied twice daily. Topical steroids are effective. However, they can thin the skin with chronic use. They can cause bruising. Topical calcineurin inhibitors only come as a cream or ointment, so they're greasier. They're considered to be less effective than topical steroids when we're talking about high strength, but for areas like the face, the folds, topical calcineurin inhibitors are very effective. And an example would be topical tacrolimus or topical pimecrolimus. And the brand names are Protopic and Elidil. And the one caveat to be aware of for topical calcineurin inhibitors is that they can burn with initial application. It doesn't cause any damage to the skin, but it can cause a burning sensation. So sometimes to mitigate that, we will first start with topical steroids and then eventually transition to topical calcineurin inhibitors when the initial severe inflammation of the skin is calmed down. If a patient presents with widespread cutaneous GVHD, acute cutaneous GVHD, we always speak to the transplant physician because at that point, systemic therapy is typically indicated. If the GVHD is widespread but not very symptomatic, and there is a reason not to give systemic therapy, there's a contraindication, then we may recommend narrowband ultraviolet B phototherapy, which is off-label but is approved for conditions like atopic dermatitis or eczema and psoriasis, and can be effective, and this can be administered both at home and at a dermatology office. The other reminder for any rash that you experience post-transplant is now in the age of telehealth and easy communication with your physician. Always take photos. Take photos because they timestamp when something happens. It's something that you can always reference if the rash changes, when it started and how it first presented, and they're really helpful. Send them to your provider through the portal or whatever communication method you have available to you, and these will be very important for helping manage your disease. So how does phototherapy work? So there are three main types of phototherapy that we prescribe. Ultraviolet B is the type we prescribe for patients with both acute graft-versus-host disease of the skin and a non-scarring chronic. And this one, as you can see with this arrow, really penetrates just down to the basal layer of the epidermis. So the top where you can see these cells, that's the epidermis, and below it where you see blood vessels and veins and lymphatics and then fat, that's the dermis. So really, ultraviolet B, it penetrates down just through the epidermis where the process of acute graft-versus-host disease is, and this can be is typically administered 3 times a week. And for acute GVHD, most patients require about 3 to 6 weeks of treatment. And again, this can be done in the home or at a phototherapy office at a dermatologist provider. So how do you find a phototherapy center? The American Academy of Dermatology actually has a website that you can navigate, and it's aad.org/F as in Frank, AD. And this website, you can enter your zip code, and then under procedures, you can select phototherapy, and this will provide you a list of available phototherapy providers. Then you will have to call the office and make sure that they take your insurance, and then you can set up a visit and be evaluated for potential initiation of phototherapy. So moving on to chronic graft-versus-host disease. Chronic graft-versus-host disease classically presents after day 100, but again, can present at any time depending on how the skin appears. So the first type of GVHD, chronic GVHD that I will discuss, and when we say chronic, it doesn't mean that it lasts forever. It just lasts for a longer period of time than acute graft-versus-host disease. And chronic GVHD can last for months to years, but eventually does burn out and becomes inactive. So the first type is non-scarring or non-sclerotic lichenoid chronic GVHD. And sometimes can be referred to as lichen planus-like or lichenoid, and these are all interchangeable words, and it can present with scaly, pink, raised areas and flat areas. Sometimes a network can develop on the neck that is also part of chronic GVHD. And this can be itchy, this can crack and open, or can be relatively asymptomatic. And there's really a variety of presentations. And the symptoms that you develop will also impact how aggressive we may be with therapy. Lichenoid chronic GVHD can also be extensive. As you can see, it can affect the palms, the hands, the nails. It can cause discoloration and peeling. However, it can also be localized. So there's really a spectrum, and I want to just emphasize that. Chronic GVHD can affect the mouth, it can affect the lips, and patients may develop these white, lacy areas on the lips, on the genitalia, and on the skin. And this, again, this is all non-scarring and usually responds well to topical steroids. When it affects the palms or the fingertips, this can be more symptomatic. And this is a time when we use topical steroid ointments in order to increase the penetration and also to provide a coating of lubrication to minimize the symptoms associated with really any GVHD of the palms and fingertips. So again, the treatment for chronic non-scarring skin GVHD or non-sclerotic skin GVHD is very similar to the treatment for acute GVHD topically. So topical steroids, topical calcineurin inhibitors, and narrowband phototherapy. And of course, if it's more extensive or rapidly progressive or very symptomatic, that's when we really communicate with a transplant physician to recommend a systemic therapy. And now really we have 3 FDA-approved systemic therapies for chronic GVHD, including ibrutinib, first approved, ruxolitinib, and belimosidil. So all very exciting to have such great therapies available for patients with more extensive chronic cutaneous GVHD. Moving on to sclerotic. Sclerotic GVHD is the scarring type of GVHD. So this is when patients develop GVHD where the skin becomes hard to pinch and it becomes bound down. Patients may have limited involvement or more extensive involvement. And depending on where your involvement and how severe it is, this may impact how aggressive we are with therapy. And so again, just another photo of sclerotic. So this is a little bit more superficial. This patient has shiny, scaly patches and plaques, but again, the skin is bound down. One notable thing that you may notice when you first develop sclerotic GVHD is that it can appear in areas of prior trauma. So you can see in this textbook photo on the prior bra line, the patient developed sclerotic GVHD within the bra line, also at the waistband in the right photo, and in the axilla, in the underarms of just trauma from moving the arms, and also in prior lines on the right neck and also on the right chest from a port and a central line. You can develop within the scars sclerotic GVHD. You may also develop sclerotic GVHD in areas of prior radiation. So those are some spots where you may start to see the GVHD first, and that's something where you really want to tune in and flag your physician to assess you entirely and look for other areas of GVHD and to initiate a management plan. Of course, this can be extensive to the point where the skin scarring affects the joints. And while you can have joint GVHD, you can also have just extensive skin GVHD that reduces range of motion. And you can see on the legs, it can be very tight, very bound down, hard to flex the ankle. And we assess range of motion at every visit. The way we assess the range of motion is we really ask patients to perform the position in the rightmost column. So we ask the patient to raise their arms to look at the shoulder and make sure there's normal range of motion in the shoulder, to extend their elbow, to make a prayer sign, so examine the wrist, and lastly, to examine the ankle by bringing the toes to the shin and making sure that the patient can go past the 90-degree mark. And this will tell us if the patient has tightening of the skin or joints, because tightening in either may lead to decreased range of motion. And we follow this at every visit. Sclerotic GVHD, when the skin scars significantly enough, it can, even with mild trauma or no trauma, can ulcerate and make a wound that can be chronic or short-lived. But this is something, if you notice any small wound forming, there's great wound care that can be performed to minimize the progression of the wound, and we need even more aggressive systemic GVHD therapy. And so definitely let your physician know, definitely take a picture and bring this to attention as soon as possible. So topical therapies for chronic scarring or sclerotic skin GVHD are really minimally effective. We rely on systemic therapy as per the transplant physician, and again, treatments that are approved and have efficacy in sclerotic GVHD include the ruxolitinib, the Minoxidil, and the ibrutinib, and off-label treatments like extracorporeal photopheresis. Topical steroids, because the scarring is deeper to the top layers of the skin, really don't penetrate well. There are very superficial forms of sclerotic GVHD where the topical steroids and topical calcineurin inhibitors may have some efficacy, but really most of the sclerosis is deeper, so there's usually limited efficacy with the topicals. Wound care is very important to reduce risk for infection and to help heal the skin and improve the quality of life, because living with wounds can be painful, can be bleeding, can be malodorous. So really we want to treat these, and chronic wounds put a patient at increased risk for skin cancer within the wound. So we definitely want to manage these. When a patient develops generalized sclerosis, also the patient will be advised to start typically systemic therapy as per the transplant physician, and that may oftentimes include, if the disease is progressing rapidly in the skin, it may include systemic steroids as well to really try to control the sclerosis as quickly as possible. Because most sclerosis starts slowly, and many therapies in chronic GVHD, we also expect to act more slowly. So really, time to improvement in chronic GVHD can usually be about a couple of months to see any notable improvement. So if you are started on a systemic therapy, don't give up hope if you haven't seen changes in the first month. Really, depending on the therapy, usually a couple of months is where you start to see improvement. And then UVA1 phototherapy, and historically we did recommend PUVA, which is psoralen with UVA, but that increases significantly the risk of skin cancer and of both non-melanoma skin cancer and melanoma. So we typically try to avoid PUVA these days because there is UVA1 that is available that does not require psoralen. However, this is not readily available. There are a few centers in the country that do provide it, and so that may be more challenging to find. However, now that we have these systemic therapies that are FDA approved, we typically rely on those in lieu of phototherapy. And now shifting gears away from GVHD to other side effects that we see in patients who are being treated with systemic steroids, typically for GVHD. So stretch marks, also known as striae, may develop with prolonged systemic steroid use. And you can see in this patient, the patient has atrophic skin or really thinned skin, and these can be quite extensive. This patient has these stretch marks on the arms, on the back, and when the skin is so thin, the integrity is so poor that even light trauma or movement can cause an open wound. And so how do we treat this? We can treat stretch marks. They're very challenging to treat, but we can use certain treatments to help with the cosmesis or how they look, and sometimes to help with the skin integrity so they're less likely to break down. Any stretch mark on its own remodels over a year and continues to improve with time. So even if you do not treat it, it will lighten and it will slowly improve. But treatment can expedite that. Treatments that are available and that have variable efficacy. For example, topical tretinoin is a vitamin A derivative, and it can improve early stretch marks. So when a patient first develops that stretch mark, if it's used daily or twice daily for 6 months or longer, it can reduce the length and the width of the stretch mark. And so you can see in this picture here from a study back in 1996, this patient had used tretinoin for 6 months, and then for another nearly a year and had significant improvement. And this is keeping in mind with the fact that the stretch mark on its own is also improving. And this is the best response of their series of patients. And this is another patient who used for half a year and had really impressive response with the tretinoin. But again, they chose the best response, and most patients have a mixed response, and it's not quite as good, but it is something that some patients may reach. The side effects of tretinoin is really can cause dryness, erythema, which is pinkness, or skin peeling with treatment. And so keep that in mind that you can take a stretch mark can be asymptomatic without any symptoms, and then applying this tretinoin can actually make them symptomatic or cause itching and peeling. So that's something really to keep in mind, weighing the risks and benefits of any intervention. Stretch marks may also be treated with a laser. So depending on the type of stretch mark, we use different types of lasers. So if you have a pink stretch mark, as you see in the top portion of this picture, we would use a pulse dye laser typically. Pulse dye laser targets the vessels in the stretch marks, and that's why it works well for this. The pulse dye laser does not create sores in the skin typically, so it can even be used if a patient is on systemic therapy that's immunosuppressive. If you're trying to target the thin texture in a stretch mark, usually a fractional CO2 laser or erbium-YAG laser is used. And the fractional lasers work by creating little microscopic holes in the skin that stimulate collagen to rebuild and increase the strength of the skin there and reduce the thinness. So because this laser creates little holes, we typically advise patients to be on minimal immunosuppressive therapy, essentially no steroids ideally, or very low steroids, because with these holes, we do put a patient at risk for skin infections. So really this one we reserve for when the patient is mostly off of systemic immunosuppressive therapy. And this is an example of the fractional CO2 laser, and this is just after one treatment and 3 months after the treatment. So on the left side, you can see the A and B photos. So after one treatment, you can see that the stretch marks are minimized, they're less white, and similarly on the right two photos. So again, just one treatment. It really does help the overall appearance. Another treatment for stretch marks can be microneedling, and this can be safe and effective. In this case series, the stretch marks improved by over 50% after just 2 treatments. And the main side effects of microneedling, which is typically a roller with needles, is really transient pinkness. So this is another treatment. A lot of these treatments are not covered by insurance, so that's something really to keep in mind. So one of the main side effects of all these treatments is really the financial cost. So you have to bear that in mind with any of these recommended treatments. And now shifting gears to skin care when you have GVHD. So hand washing is something that is very important when you have GVHD to reduce the risk of infection. Of course, hand washing is also associated with dryness, and skin cracking can also increase risk for infection. So how do we hand wash but keep our hands moisturized? So every time you wash your hands, we usually recommend washing under 20 seconds with lukewarm water. Then you dry your hands with a clean towel, leave some water on your hands, and apply a fragrance-free moisturizer. The best soaps to use, really avoid anything with triclosan or anything that says antibacterial. Any soap is great, but really an unscented bar soap is what we recommend. For these showers, we recommend showering or bathing for less than 20 minutes with lukewarm water, and also, again, using that gentle fragrance-free soap or cleanser, and moisturizing immediately after the shower. So patients often ask, in what order do I apply the skin products when I have GVHD? So the first thing you will apply is after the shower, after you come out of the shower and the skin is still damp, even before the moisturizer. If you have a medicated cream or ointment that you are supposed to be applying to treat the GVHD, that goes on first, because we want the medication to be in direct contact with the rash that you are treating. So the first thing you do is you apply your medicated cream or ointment, and then you can let that dry, and then you can apply a moisturizer, then a sunscreen, and then makeup if that's something that you're interested in, or if you have a social event, as long as you do not have broken skin. How do you choose a moisturizer? So you choose an ointment or a cream. Lotions are typically less moisturizing because they have a little bit of alcohol and they can evaporate. Next, you can apply a petroleum jelly or moisturizer when the skin is damp. It locks in the moisture under the moisturizer, so that's really important. And if you want to further seal in the moisturizer, you can cover the moisturized hands or feet with cotton gloves or socks to seal that in further, especially overnight. How do we choose a sunblock when we have skin GVHD? So there are two main categories of sunscreens. One is chemical and one is mineral. Chemical, if you look at the back of the sunblock, will have ingredients like octinoxate, oxybenzone, or avobenzone. These are typically easier to spread on the skin. They don't leave that white residue. They're available in water-resistant options, and they may be best if you do not have sensitive skin. However, if you have broken skin or sensitive skin, the best sunblocks are really zinc oxide or titanium dioxide. They're thicker. They do not rub into the skin very easily. They do leave a white or purplish residue, but they are the better choice for sensitive skin. We always recommend applying broad spectrum, which means it protects you against UVA and UVB light, and SPF at least 30 and above, and oftentimes we recommend 50 and above SPF to reapply to apply 20 minutes before you go outside. Then you choose broad spectrum, as I mentioned, and to avoid the sun between the hours of 10 a.m. to 4 p.m. To reapply sunblock really every 1 to 2 hours, or if you feel you're burning. And the most effective thing is really to wear clothing that protects your skin from the sun. So regular clothing like long sleeve shirts, wide brim hats, sunglasses, all work. And if you have access to ultraviolet protective factor clothing or UPF clothing, that's even easier, especially if you have broken skin because it's so effective at blocking out the light. And the most important is really just avoiding the sun during the peak hours of sunlight where the sun is strongest, so really 10 a.m. to 4 p.m. So if you want to go to the beach, that's something you could do, just it would be in the early morning with a lot of UPF clothing, sun protection, and a big hat. And the sunglasses also protect the eyelids and the periorbital area from skin cancer as well. So really all important areas. And one caution I do want to caution everyone is if any patient that is ever treated with voriconazole, this is very, very photosensitizing, which means it makes your risk for burning very high. So on that medication, you have to have even stricter precautions, even be more sun avoidant than other patients when you are on that medication. And then how do you use makeup when you have skin GVHD? So we tell patients to choose fragrance-free products made for sensitive skin, to avoid any products that are natural or unpreserved, because these can have germs that can cause a skin infection. Try one product at a time every few days. You may have new allergies after the transplant, even to products you used previously. It's okay to use makeup to cover a rash as long as the skin is not broken, and it's okay to use concealer to cover dark spots or light spots that may have appeared after a rash has resolved. Very important to replace makeup products when you have skin GVHD. Throw out your older products and buy new ones after your transplant. You really want to start fresh. Replace mascaras every few months, eyeshadows at least every year, foundation at least every 1 to 2 years, and lipsticks and blushes at least every 1 to 2 years. This is really important because these makeups can really harbor bacteria, and little cracks in the skin with the bacteria in the makeup can lead to a skin infection. So you really want to replace these things regularly. Now, nails. Many patients experience nail changes from their GVHD, and these can be non-scarring nail changes and can be scarring nail changes. We see findings of brittle nails, oftentimes post-transplant, even without GVHD. So what do we do for these? These can be asymptomatic, where it's really just the appearance of the nails, or they can be very uncomfortable, harder to unbutton buttons, harder to type, harder to text, etc. So what do we do for this? So, and some patients may experience loss of nails, which is more rare. more rare and typically requires systemic therapy, and if it's in the setting of other systemic GVHD. So for brittle, breaking, lifting, and scarring nails, we recommend two main products. So Sally Hansen Hardest Nails is really readily available. This is a nail lacquer that can harden the nail and really just needs to be painted on a few times a week, and this can help protect the nail. Nail Tech has a range of products for brittle, soft nails, and these also can harden the nail and protect the nail. For nails that have cracks, if they've cracked somewhere in the middle, sometimes we employ things as simple as Band-Aids just to protect the nail from snagging at clothing. Oral biotin, even though it has not proven to be very effective for hair regrowth, it actually is effective for nail hardening. So that's something we do often recommend over-the-counter oral biotin supplements. And high-potency topical steroids, if there's an inflammatory component, can be used. If, for example, if a patient has GVHD in the skin in other areas and the nail is becoming thinner with that, like I showed in the prior photo, this is when the high-potency topical steroids can help. If the nail is if the patient is starting to lose their nail, and it's not chemotherapy related, as that can happen after the initial transplant, but really in the chronic phase, starting to lose their nail, we can do some steroid injections into that nail fold, into the cuticle, which is painful but can be effective. And then if a patient starts systemic therapy for other GVHD, then that would also typically help with the nails. It takes 6 months, even if you have effective treatment of your nails, it takes 6 months to grow out a new fingernail and about 18 months to 2 years to grow out a new toenail. So really the area you'll look for a new nail growing out normally is right at that closest cuticle to you. So if the nail is looking normal there, that's a great sign, and then you just have to give it time to grow out normally. And most transplant recipients experience hair loss. Another term for hair loss is alopecia. Alopecia just means any type of hair loss. Most transplant recipients first experience anagen effluvium, and this is the hair loss in the first 6 months after chemotherapy, and this is chemotherapy related. If the chemotherapy hair loss becomes persistent, where we call it persistent chemotherapy-induced alopecia or hair loss, we call that if the hair loss has lasted over 6 months after chemotherapy, there are other treatments we can employ to help it regrow. And then patients may also experience GVHD-associated hair loss, and that can occur as part of chronic GVHD. So GVHD hair loss may be scarring or non-scarring, and so you can see there's thinning in the leftmost photo, and on the scalp there's really, this is a close-up of the scalp with the hair follicles. There's some pinkness, but there's no scale. And then on the third photo, you can really see scale and inflammation that we have to target, and the rightmost photo is really scarring. And that's where patients can lose the hair follicle, and once you lose the hair follicle, you cannot regrow the hair. So really, if we start to see scarring in the scalp, we want to be aggressive in treatment. So topical treatments for GVHD of the scalp and the hair. So if you see hair thinning, fine hairs after transplant, if there's inflammation, there's scale or pinkness, we typically recommend a topical steroid solution, and usually oral Minoxidil, which is oral Rogaine. Topical Rogaine may also be used, but oral Rogaine is typically easier to take. It doesn't have to be applied to the whole scalp. If you have some hair, it doesn't make it oily or greasy, etc. If you have no inflammation, we typically just recommend no topical steroid, but just the oral Minoxidil and or oral finasteride for males and postmenopausal females. If there is scarring, we still recommend that oral Rogaine or Minoxidil, and patients, once their GVHD is burned out, may be candidates for a hair transplant. So Minoxidil works by prolonging the growth phase of the hair cycle, and it helps the hair cycle in a way where they grow thicker to the patient's baseline. So it's not going to make it thicker than your other hairs, but if your hairs were thicker before they are in the past than they are now, it'll thicken them up to that hair width. In this study, these two patients, the left column is someone who had received Minoxidil, the right column is someone who had received placebo treatment, and they took their Minoxidil during their chemotherapy, And the person who had Minoxidil experienced hair regrowth faster by 50 days than the person who just took placebo. So while it does not prevent alopecia, it really reduces the period of hair thinning and baldness. So this is something that's usually well tolerated. We give it at very low doses, and the main side effects are really excess hair growth on the face, rarely some leg swelling. And in higher doses, it could lower your blood pressure, but we really give very small doses. And Minoxidil may also help appearance of scarring graft-versus-host disease of the scalp by increasing the background hair density. So this patient has scarring on the top of her scalp, and while we can't reverse the scarring, what we can do is we can start Minoxidil and we can thicken the background hair so that she has more fullness despite having areas of hair loss that we cannot regrow. So this is after 12 months of Minoxidil. So how do we take care of our scalp when we have GVHD of the scalp? So we recommend washing and conditioning your hair every 2 to 4 days, using a shampoo and a cream rinse or hair conditioner. And then when you brush your hair, start at the end. Use a soft bristle brush or comb or even your fingers really to be gentle to your hair. And then if you have any scale to really treat that dandruff, you can use an over-the-counter antifungal shampoo like Head & Shoulders or Selsun Blue, or you can ask your provider for a prescription ketoconazole shampoo. And even though these antifungal shampoos are called shampoos, they're really to treat the scalp. So it's really important to lather that shampoo, the antifungal shampoo, onto the scalp for about 3 to 5 minutes so the medication has time to work on the scalp. It does not need to go anywhere else on the hair, and then you can always apply whatever shampoo or conditioner you like to the hair itself. So how else do we mask? There's makeup for hair. So we can mask hair loss in different ways. There are powders, lotions, and sprays. And so pigmented concealing powders can camouflage hair thinning. So this is just same-day application of a camouflage powder. You can see how much thicker this area appears. And hair transplantation may also be used once the GVHD is inactive. So the advantages of hair transplantation is that it's effective and permanent, and it's performed under local numbing. However, there's a risk of scalp swelling, scalp bleeding, minor infections. It can look unnatural in some patients. It can create a donor site scar. So if they're removing hair from the back of the head, this can leave a scar, and ultimately it's expensive because it's not covered by insurance. There's also micropigmentation. This is something that can really be used well in darker skin types, and this recreates the appearance of hair follicles. So an advantage, it's relatively permanent. It can look like pores on the scalp. There is a small risk of infection from the procedure. Patients may develop an allergy to the pigment used for the micropigmentation, and the natural hair has to be dyed to match the pigment because there are only so many pigment colors. And patients may need touch-ups over time as the pigment fades. So this is a nice additional option. So I'm going to end here and happy to take questions, but in summary, acute graft-versus-host disease of the skin presents as a maculopapular rash or a pink rash. Chronic graft-versus-host disease may affect the skin, hair, or nails. Many treatments are available that improve quality of life, and we encourage you to notify your care team if you develop signs or symptoms of skin, hair, or nail GVHD so that we can address them. And in the age of telehealth and readily accessible cameras, always document any new rashes with photos. Take more photos. We'd always be happy to see more photos in order to have a better timeline and understanding of what's going on with you and your skin. Our overall goal is to improve your quality of life, and there are many things we can do for you. So I'm happy to take questions. Thank you.
Thank you, Dr. Markova, for this excellent presentation. The first question is, what is the difference between red light and phototherapy?
That's a great question. So phototherapy is used for the treatment of inflammatory skin conditions. So things like eczema, psoriasis, and GVHD, cutaneous lymphoma. This works by increasing the regulatory white blood cells in the skin to reduce the inflammation. Red light is really less well studied. It can be used for different things, like in photobiomodulation to reduce the onset of sores in the mouth. There are over-the-counter products available for hair regrowth, but they were really still experimental, mostly, except in the setting of prevention of mucositis or mouth sores. They're really experimental, so the efficacy isn't so well established, and it has not been tested for the treatment of GVHD on the skin, the red light. But that's a great question.
Thank you. Next question is, do you have any recommendations for recurrent painful lip fissures that start to heal but then crack open easily again?
That's a frequent issue that our patients experience. So the number one moisturizer for your lips is really Vaseline or 100% petrolatum ointment. So that's really important to apply many times a day. Always avoid lip licking. Our saliva has antibacterial components, and so the saliva can actually, it's like a soap. It can really dry out the lips and irritate them. And then if there's frequent lip cracking, it's really important to get assessed by a dermatologist. There are many different causes for lip cracking. Things like GVHD can affect the lips, and in which case you would want to use a topical steroid. After transplant, patients are at increased risk for skin cancer. And so you can also develop skin cancer on the lips, and they can be this pre-skin cancer on the lips that's called actinic cheilitis. And so it's important for a dermatologist to make sure that's not what's going on, because then we could treat with a special blue light or red light for the treatment of skin cancer. And also infections can occur. There can be candidal infections, yeast infections, or viral infections. So really, if it's not responding easily to Vaseline, petrolatum, or Aquaphor, I would reach out to a dermatologist in order to help you address that.
Thank you. The next question is, how do you assess trunk scleroderma? Have you seen any benefits with myofascial manual therapy for this?
That's a great question. So trunk scleroderma is very challenging to assess. As I'm sure your providers have done with you, we typically do try to pinch and see how much laxity there is and follow it over time, follow the comfort in breathing over time, and really rely on the patient assessment. The patient oftentimes will feel like their eating is better, their breathing is better if their trunk scleroderma is very tight and starts to soften. There have been some tools that have been investigated, like ultrasound and other devices, but also all experimental in order to determine the improvement in the tightening. But we follow with photos. That's really what's best, and patient reports. And as far as myofascial, it is something that, when available, we do sometimes incorporate if a patient is motivated, and patients have had some good responses to that therapy.
Thank you. There are a few questions here about the treatment of your fingernails, so I'm going to try to combine them. They want to know what particular treatment you might suggest for nails. Someone wanted to know if biotin was good for thinning nails. Will my nails ever come back to normal, or will I eventually lose them? There's a lot of nails.
Absolutely. Absolutely. These are really, so it depends on what's going on with your nails. If it's brittle nails, biotin is very helpful. We prescribe anywhere from 2.5 milligrams to 5 milligrams daily to supplement this, and usually about a 2-month course is enough to provide that nail hardening. To keep in mind with biotin, biotin is not dangerous in any way, but it does interact with one test that we check if you're experiencing any sort of cardiac symptoms, like heart symptoms, for example, a heart attack. So it affects the test, so the lab processing of the test. So if you are taking biotin and you do take some supplementation and you are being evaluated for anything cardiac, or you're just going in the emergency room for any reason, just tell the providers there that you're on biotin, because they will check you in a slightly different way because, again, it affects the lab test. So just one warning about the biotin. But anywhere from 2.5 to 5 milligrams per day is an adequate dose, and we usually treat for 2 months. For the nail hardening, the nail lacquers, I mentioned the nail tech, as well as the nail tech, as well as the Sally Hansen Hardest Nails do work well. Also having an evaluation for nutritional deficiencies, certain nutritional deficiencies, especially if you've had a history of graft-versus-host disease of the gut, can predispose you to nail changes. If you have ongoing systemic GVHD and you have associated nail changes, when you are treated for the systemic GVHD and it responds, the nails typically also improve, but there's like a 6-month lag period because it takes 6 months to grow out the nails. If you have scarring of the nails, sometimes they do not regrow exactly the same way. And that is the one hard thing. If you have sclerotic GVHD, sometimes you can scar over the nail matrix, which is the part of the cells that produce the nail. So it really depends on the type of nail condition you have, how well they respond. If you have just the nail changes after chemotherapy that you had for the conditioning chemotherapy for the transplant, those typically all grow out in about 6 months in the fingernail. So it really depends, but those are some of the treatment options.
Thank you for that. I use a topical steroid ointment for mild GVHD on my back. If the spots fade and itching is reduced, should I continue to use the ointment?
So a very good question. And because topical steroids over time do thin the skin, if the spot fades, we typically actually advise patients to switch to moisturizers, and then if anything recurs, to really restart, or if there are any symptoms, to restart. Some patients will also do a maintenance treatment. So basically, if everything goes away, once a week they'll just put a topical steroid there just to maintain it if there's still active GVHD in other parts of their skin. But if really you treat and it's gone, you do not need to keep using it because, again, there are side effects with the topical steroids, including skin thinning and bruising, and those are really hard to reverse.
Thank you. For dry skin, this is kind of a two-parter. For dry skin, besides Aquaphor ointment, is there anything that you can recommend that's not quite as thick? And then someone had asked if you could use coconut oil as a moisturizer. So 2 parts there.
Absolutely. I always tell patients that the best moisturizer is the one you're willing to use. So if it's coconut oil, if it's olive oil, if there is a moisturizer you like and you're going to use it every day or multiple times a day, that's the best one. But if you're very compliant and you're eager to use any moisturizer, then I typically recommend creams. And so slightly less greasy than Aquaphor or Vaseline are Cetaphil and CeraVe creams. Some patients actually, there's an Aquaphor spray that's less greasy than the Aquaphor itself, but it's still very moisturizing that patients like as well. But really, if there's an oil that you would like to use, go for it. Just use it frequently, and that's what's most important.
Great, thank you. How effective have you found ECP treatment for scleroderma skin, GVHD? That's
an important question. So for sclerotic GVHD, there are now the 3 FDA-approved therapies, the ibrutinib and the belmocidil and the ruxolitinib. So typically with our patients, we do initiate systemic therapy with one of the FDA-approved therapies first. But in patients who have a contraindication to one of the FDA-approved therapies or prefer to try something like extracorporeal photopheresis, it is something we do recommend and we do see good responses with, but keep in mind it is something that requires a line. Typically, most patients are unable to receive it through the IV because it really requires a big gauge needle and the veins can scar over time. It requires a long period of treatment. We expect oftentimes about at least a year of treatment, and it's a burden because it can require twice a week treatment for several hours each treatment. So although it is tapered over time and can be used less frequently. So it is something that is great because it does not reduce your immune system. and can really work and target all organs in chronic GVHD, but it does require time commitment and a line, and sometimes puts you at risk for infections through that line. So those are the risks and benefits, general risks and benefits. But it is something that we have seen good responses with for sclerotic GVHD.
Thank you. This kind of goes back to some initial questions. Someone wants to know what myofascial treatment is.
That's a great question, and so this is not frequently available in many places, but it's something that where we usually refer to a physical therapist, and really it's a massage. It's a gentle massage that can help release tightness in the skin, and so but it's a medical massage, and there are some that are some physical therapists that are and lymphedema experts that are trained in this, and this can improve the circulation and the lymphatic drainage, et cetera, especially in our patients who have sclerosis on the limbs, where the lymphatic drainage of that limb is impaired. And so this kind of myofascial release or massage can really be helpful in draining that fluid from that extremity.
Thank you. What can we do with the stretch marks and cellulite produced by Jakafi?
So typically with Jakafi, Jakafi is ruxolitinib, it's an oral Janus kinase 1-2 inhibitor, so an oral JAK inhibitor. We typically do not see stretch marks and cellulitis directly related to it. What we do see stretch marks related to is really steroids, and the cellulite-like changes we see in sclerotic GVHD, and that's typically a side effect of the GVHD itself. So when the sclerotic GVHD affects the panniculus or the fat, it causes scarring within it, which can simulate an appearance of cellulite. And I always tell patients, if you ever start to see new cellulite appear that is more rapid in onset or atypical, always reach out to your clinician so that we can assess it, because that might be evolving GVHD. But we don't typically see cellulite or the scarring with ruxolitinib, although we see it in patients who are being treated with ruxolitinib for sclerotic GVHD or who have had systemic steroids in the past.
Thank you for that. 2 hair questions. One, is it safe to dye my hair after transplant? And the second part is, do you recommend Nioxin shampoo?
Great questions. As far as it's safe to dye your hair, as long as your skin is intact, it typically is safe to dye your hair. I still always advise you to confirm with your bone marrow transplant physician, because if you have an active rash on the skin sometimes, or previous rash on the scalp, sometimes we may avoid hair dyeing for a short period of time so that we don't stimulate another reaction in that site, and we can really stay on top of managing the GVHD. But really, once things are quiescent, and as long as you don't have broken skin, we encourage any sort of hair dye to really allow you to really enjoy your survivorship. As far as the Nioxin, there's no great evidence for it. It's not, there's nothing, it's not harmful based on the ingredients. So if it's something you enjoy using, and then it's okay to use. But as far as mechanistically, there's no great evidence for hair regrowth with that product.
Thank you. This person is concerned. They would like to get a manicure after transplant, and they're concerned about the tools that they use at the manicurists. Will they be? Absolutely.
So if you get any sort of manicures or pedicures after transplant, we always recommend to bring your own tools that you've pre-sterilized, so either with alcohol or any sort of kind of hot water, soap and water, and only use your own tools. I also typically actually recommend bringing your own nail polish as well. And if you're using any water, not to use any of the sinks, like the tubs for the feet. Really, if you use a bowl of water for your hands or a bowl of water for the feet, so that you're not exposed to the bacteria in the plumbing and in the actual tubs that they have there. But it is possible to get it done. I also advise against cutting any sort of cuticles, really just sticking to cutting the nails and really minimizing any sort of skin trauma.
Thank you. Is there anything that can be done about steroid-induced very thin skin?
This is one of the biggest challenges we have with topical and systemic steroids, and it is very hard to reverse. Really, the best thing we can do is moisturize, and in some patients who can tolerate it, where there's a particular area, we can try the tretinoin cream, which is the retin-A cream or the vitamin A derivative cream, which can help thicken the collagen, but it's otherwise very, very hard to reverse that steroid atrophy or the skin thinning that you get with steroids, unfortunately. So the best thing you can do is really protect the skin by moisturizing so that it doesn't open up with light trauma.
Thank you. And this will have to be our last question. I had skin GVHD, and now the areas are darkened in the affected areas. How long does this take to clear up? Is it months? Is there anything I can do to speed up the process?
Absolutely. So this is something that we can treat. So with dark spots, on their own, they do lighten over about a year and really do fade over the year. Anytime you have sun exposure, they can re-darken. So we strongly recommend wearing sunblock whenever you're outside. As far as lightening, there are over-the-counter treatments that are available, that have hydroquinone 2%, but really the best is to get a prescription for the stronger hydroquinone treatments, such as hydroquinone 4%. One product that works well has hydroquinone, tretinoin, and a steroid, and that's called Triluma. And some pharmacies compound it as well, and those work well for lightening. Patients can also receive chemical peels to treat the skin darkening. Depending on the skin type, we may recommend a different regimen for lightening those spots, but that is something that can be treated.
Great. Thank you, Dr. Markova. On behalf of BMT InfoNet and our partners, we'd like to thank you for a very helpful presentation, and thank you, the audience, for excellent questions. Please enjoy the rest of the symposium.